Hello and welcome to Matters of the Heart, a program on cardiology and cardiovascular issues. My name is Dr. Sunny Srivastava and I'm a cardiologist at Pentucket Medical Associates here in Haverhill. And with me today is one of my associates, Dr. Seth Bilazarian, also a cardiologist at Pentucket Medical Associates. And today we're going to talk about something called peripheral arterial disease. So I'll launch right in and just ask you, what is peripheral arterial disease and why do we care?
Well, peripheral arterial disease, sometimes goes by the abbreviation of PAD, is a disease involving the arteries, arterial, and doctors refer to it as peripheral because it's away from the heart. So peripheral arterial disease most commonly refers to leg artery problems. It can refer to other problems, but outside of our sort of central part of our body, the peripheral part of our body is called peripheral arterial disease. Most commonly relates to the leg arteries is the one that we most commonly are concerned about.
Okay. And what type of symptoms do people have when they have peripheral arterial disease? How would one present to you in the office?
Well, the way peripheral arterial disease can present on the sort of early side from a symptom standpoint with patients is with leg discomfort. So patients have a problem called claudication, which is a problem that causes discomfort in the calf behind the knee, in the back of the leg, which occurs with walking. So a patient will come to me to answer your question, say, I can only walk 50 steps before I get real pain in the back of my calf, causing me discomfort that makes me stop and rest and recover. That's the earliest presentation of claudication or peripheral arterial disease. Peripheral arterial disease being the problem and claudication being the symptom. Two more concerning problems that can happen with peripheral arterial disease are really jeopardy of the leg. Physicians call this critical limb ischemia, or more commonly limb jeopardy. So everyone knows what jeopardy means. So sure. If our limb is in jeopardy, that's worrisome. That means that blood vessel supply to the leg has become so limited that we might be at risk. And the risk could be problems with healing of a wound, or it could be problems that result in the leg actually having real problems like gangrene, and which requires a leg to be amputated. To answer the question about that, that was really the symptoms related to presentations. But we also worry about peripheral arterial disease because it can be a hallmark of problems even before symptoms. If we identify patients who have peripheral arterial disease even without symptoms, it can be a really important marker for other vascular issues.
Well, along those lines then, what type of patients or individuals are at risk for developing peripheral arterial disease?
So in terms of peripheral arterial disease, it's like other vascular disease. We can't say that all patients who have peripheral arterial disease will have other vascular disease, but they do keep company with one another. Sure. So when we think about the different vascular areas of our body, we think about the vascular area of our head, which would involve the blood vessels to the brain, which could cause a stroke. We think about the blood vessels of our heart, which of course could cause a heart attack, and then these peripheral arterial vessels of the legs. So those are sort of the main three realms. So the peripheral arterial disease issue is really one that can be very important to identify. And the people who get this, of course, are the same people who get vascular disease in the other areas. And I think we have a graphic of the age relation with regard to peripheral arterial disease. It certainly increases with age, and people who are older are more likely to have peripheral arterial disease. We don't commonly see this before age 50, but it can happen in people who are less than 50, particularly with certain important risk factors.
Okay.
The risk factors that we worry about with all vascular disease are 5 important risk factors, but peripheral arterial disease has 2 of the more important risk factors, and those are cigarette smoking and diabetes. Those 2 are really big, important risk factors for peripheral arterial disease. They also, of course, have other important contributions to risks for heart arteries and our arteries of our brain, but those are really important for the lower extremities. The other 3 important risk factors we mentioned of the 5, I mentioned diabetes and cigarette smoking. The other 3 are high blood pressure and high cholesterol. And then the 5th one is a family history of vascular problems. Sure. So all 5 of those are risk factors. Age is, of course, something that is an important part of this because the longer we have these risk factors, the more likely we're going to have problems with them.
Great. I guess what I want to ask next is if I were to walk into your office and say, Doc, my calf hurts when I walk a couple of blocks, what happens from there? How do you evaluate this?
Well, like all cardiology problems, or I guess I could say more broadly, all medical problems, It really starts with a conversation between the doctor and the patient. And that's what doctors call history, taking the history. So as you said, if you told me every time I walk into your office, doctor, across your parking lot, I have to stop and I have pain in my calf or it really hurts, I have great difficulty, that's very suggestive. There are other things that, of course, can cause problems of leg pain with walking. Arthritis, for instance. There's a problem called spinal stenosis. There's a variety of things that can cause this, but there are certain presentations that make us think that circulation is more likely the problem. And this pain in that calf area in the back of our leg is a big suggestive problem that can make us think about it. So the history is, of course, the first part. And then the second part that doctors worry about is the physical exam. Just looking at someone's feet, checking the pulse to see if there's good arterial supply to the leg is an important part of this. So checking the feet or foot pulse check, as you can see on our graphic, is an important thing. And then there's some basic testing that can be done, and of course some more expensive advanced testing that can be done. But I want to talk a little bit about the first thing that's mentioned here called the ankle brachial index. It's really a wonderful, crude, simple test that can really be very helpful for us. What the ankle brachial index means is a really simple thing. We measure the pressure in the ankle. So we do a blood pressure of someone's ankle. Just like when you go to the office, we measure your arm pressure. This time we measure your ankle and the pressure in your ankle. The pressure in your arm is called the brachial because it's the brachial artery we're measuring the pressure in. So we then take a ratio of the pressure of the ankle and compare it to the pressure in the arm. And if there's no blockage, we would expect them to be the same. The pressure in all the circulation should be the same. If the pressure in the leg is lower than the pressure in the arm, we suspect a blockage. And if we say it's less than 90%, it's significant. But if it's less than 70%, it's more significant. Less than 50% is severe. So let's use an example. If, say, someone has a blood pressure in their arm of 160, that would be high, but let's just say that's 160, and the pressure in their leg is 80, that would be only half. 80 over 160. That would be a 50%, or 0.5 would be the ankle brachial index. That would be an indication of severe blockage. We don't know much detail about it. We just know that there's now a problem. There is an artery blockage. It's a wonderful basic test to evaluate it, and it can be very helpful.
So once you have that information, let's just go back to the example of me coming into the office and saying my calf hurts. And I go get one of these ABIs done, and it's abnormal. What next? What do I do next about it? Or what do you do next about this?
Well, the ankle brachial index problem helps identify that you do have a vascular problem. Let me take an aside a little bit and talk about why this is a really important thing. We've been talking about a patient who might come in with pain in the leg, but I want to just take a moment to talk about identifying this problem as an important predictor of risk for vascular problems. So people will often say to me when they're in my office with me, and they may say it to you as well, what can I do to know that I have a problem? I'm worried because my family member may have had a heart problem, my brother might have had a heart attack, my mother had a stroke. People say this to me, what do I need to do? I'm worried, what can I do? And we talk about a lot of options. Today you and I visited with an internal medicine physician and talking about how patients often say to their primary care doctor, what can I do to prevent problems? What can I do to identify problems? There's all kinds of things that we can do, and a lot of them aren't very good, and a lot of them are very expensive. For instance, an EKG. Patients will say, should I have an EKG, a basic rhythm test of the heart, to evaluate for risk? You can have one of those, but it's not very good. It won't really help us know whether you have vascular problems. There are a variety of other tests that can be done, like a CAT scan. People talk now about getting a whole body CAT scan. It can be very expensive. It can cost $1,000. It can be a good risk predictor, but it's very expensive. This test I just mentioned, the ankle brachial index, is a wonderful test, and it's actually been shown to be one of the best tests to predict vascular risk, to predict risk for strokes and heart attacks. Because if you have a blockage between your heart and your ankle, it will be picked up with this very simple pressure test and can be a very valuable predictor of future risk. It can help us say, you really need to get going in terms of risk prediction, risk factor modification, like smoking, cholesterol, diabetes risk. So it can be very helpful in that regard. But I'm sorry to get off track because you asked me the question, what would I do if I was suffering from pain in the calf with walking?
And then I had an abnormal ABI.
Right.
So then what's the next? What happens after there?
So in the patient that you said before I went on my tangent there,
right.
talking about patients without symptoms, talking about patients who have a problem and their pain is in their leg, and we do the ankle brachial index. Well, we've done it now, and now we firmly believe it's a vascular problem. This patient has peripheral arterial disease because they have an abnormal ABI. What should we do going forward? And there's a variety of approaches, and those approaches include very simple, low-risk, non-invasive testing like ultrasound, and it can expand up to more advanced testing like an MRI or a CAT scan. Here in our graphic, we have an ultrasound which is done in a variety of settings. It's done in heart ultrasound. It's done in ultrasound of the carotid arteries. This is an example of an ultrasound done in a leg artery. And the normal flow areas seen on the picture are in red, but in the area that's in the middle of the screen where it's both blue and red is what doctors call turbulent flow. It's like a mixing of blood in a narrowed area, sometimes called a mosaic. Sort of looks like a mosaic of tiles. And that mosaic area is an identification of an area of blockage. So we can go from the ABI, which just said you do have a blockage, to help localize an exact area of blockage. So this is a really good test of a non-invasive strategy to begin. And we have this available in our office where we can actually take the ultrasound and walk down from the upper leg all the way down to the ankle to identify areas of blockage.
And in addition to, well, I guess I have a lot of questions. So one is, in addition to the ultrasound, are there other tests that you might use that could be better than the ultrasound, or is there a downside to the ultrasound, or is there anything that doesn't give you the answer you might want?
Well, the ultrasound is a really wonderful strategy because it's very safe. It's very low risk. We think there's almost no risk from ultrasound. People may know that women who are pregnant get ultrasounds of their babies while they're still in the uterus. So we think it's a wonderful, safe strategy to evaluate people with really no radiation risk or other risk. You don't even need an IV put in for this testing. So it's a really wonderful, simple, safe strategy. It doesn't give us a whole picture of the whole arterial tree, which is a nice thing to do before future plans for fixing this problem if we are going to go ahead. So what I just described is a strategy to try to evaluate basically what kind of problems exist, how many areas of blockage, how severe blockages are, but it doesn't help really plan out future strategies for patients. So would a patient benefit by an angioplasty type procedure or a surgical type procedure? Often we don't get all that information with ultrasound. Sometimes we do, but sometimes we don't. So going on to our next graphic, I would show another strategy that sometimes is done is either a CAT scan or an MRI. This is a strategy that can be done to evaluate people in a more thorough way in terms of getting a complete picture. So if we could show that graphic of either CAT scan or MRI, that would be great. And you can actually see what that picture looks like. So you can see there on the right is a picture of a person sort of from the lower chest down to about the level of the knee. And you can see the white area is a picture of the artery. And the arrow points out a severe blockage just below the belly button on the going into the left leg in what's called the iliac artery. So this is an MRI or an MRA because it's an angiogram or a picture of the arteries using the magnetic resonance. It's very nice because it doesn't use radiation again, so it's low risk. But it does require a kind of chemical called gadolinium to actually look at the arteries. And that has basically been shown to be very safe, except in some patients with kidney disease. So that is a very exciting strategy, unfortunately very expensive. Mm-hmm. So we try to be very frugal with our use of medical technology for cost containment. But it is something that's very available. Another alternative is a CAT scan, which is another alternative, which is a little less expensive. And this is a picture of a CAT scan, again, from about the area of the belly button to the level of the knee, looking at artery blockage. And in this picture, the patient has a severe blockage in the right thigh artery. The right is on the left, and the left is on the right, as if we're looking straight on at the patient, facing us. And the CAT scan is a very good strategy because it can give us really beautiful, detailed pictures. And we can then say to the patient, you definitely have not only peripheral arterial disease, which we knew after the ankle brachial index, but you have a severe blockage in your thigh, in the right thigh, in the middle of the right thigh, and treatment options are available with success for different options.
Okay. So now let's say you have, just like in the picture you showed up there on the screen, you've pinpointed a discrete, significant blockage in an individual who's symptomatic. What do you do for them? Is it just medicines? Is it, as I think you alluded to, procedures to fix it, or surgeries, or all of the above? Maybe you could talk a little bit about that.
Sure. That's really a great thing to talk about because I really want to talk to you about that, and I know you share my passion for really trying to prevent vascular problems. I mean, we obviously make a living as physicians taking care of patients. We are happy to take care of patients when they get into trouble with heart attacks and strokes and a variety of other problems, but we really want to prevent these problems. So when we have a patient who's been identified with peripheral arterial disease, before we even talk about anything else about potential treatment, we now know they have blocked arteries. So if they have blocked arteries going to their legs, they may also have blocked arteries to their heart or to their brain, and we want to aggressively treat them. So let me just show that the graphic about basic treatment strategies. We want to treat all patients with these risk factors for aggressive treatment. We know that aspirin is a powerful medicine to reduce the risk of blockages in arteries. Now, once you have a blockage, the big risk comes if you develop a clot on top of that blocked artery. The artery is blocked up from smoking or cholesterol, but the bad thing happens when that artery gets completely blocked and causes a heart attack or stroke or gangrene to the leg. So all patients get treated with aspirin, sometimes with another medicine is advertised on TV called Plavix or clopidogrel. We want to also treat the risk factors that got us into this problem. We want to use aggressive cholesterol treatment, and we commonly use medicines called statins, like Crestor or Lipitor or Simvastatin or Pravastatin, whichever medicine is needed to get people to an ideal cholesterol, to lower the cholesterol, to reduce the risk. We want to treat blood pressure aggressively. We want to treat diabetes aggressively. So we want to do all of these things to prevent a progression in all patients. So regardless of whether we're going to do any kind of other treatment, we really want to be aggressive. And this is where we often get into some conflict with some new patients. So we see a patient, again, to go back to the example patient you described, who comes in, who is having some symptoms with leg blockage, who may be a smoker. And now I'm going to tell them that I really want you to take an aspirin and a cholesterol medicine. I really want to be aggressive with your cholesterol and your blood pressure. They're not too happy with us, right. But we know that the data says that we can do a good thing to prevent not only leg problems, but heart attacks and strokes if we treat patients aggressively.
Right. So in addition to these, I guess I'll call it risk factor modification efforts, reducing the cholesterol, treating the blood pressure, hitting people over the head about smoking, treating the diabetes, exercising.
Do you hit them over the head? I usually try to hit them somewhere else.
You can get into trouble doing that,
right.
I guess. If someone still continues to have significant symptoms, and just a doc, I've done everything and it's still driving me nuts, what next? Is it just an operation, you go get fixed and it's done with, or what else can people do?
Well, I think that to make the point, though, that you've just asked about the risk factor, let me show the next graphic that we have that shows about what happens to people if they have peripheral arterial disease. And that next graphic is a series of slides showing if people have different levels of severity of peripheral arterial disease, these are called what doctors call survival curves. And if you're, the best place to be on these survival curves is on the top. So it looks like over a number of years, if you are on the top curve, it means you have the best survival. The worst curve is the lowest curve, and the patients who have the worst amount of peripheral arterial disease have the highest rates of dying. So we're not just talking again about problems with your leg or having an amputation. We're actually talking about dying here, dying from heart attacks and strokes. So that's why we are, as you said, hitting them over the head about those risk factors. So to answer your next question, we'll go to the next graphic, is to show that the cardiovascular risk increases with the severity of the worsening of the artery blockage. So again, if you have ankle brachial index abnormalities that are more severe, you of course have a higher rate of problems.
Now, I've looked at some of the graphics you prepared beforehand, and I saw some statistics about smoking cessation as we're talking about risk factor reduction. I wonder if you could comment a little bit about, number one, how important that is, and maybe even, if you feel so inclined, talk about some strategies or things that people can do to help stop smoking.
Yeah, that'd be great. Well, I'm going to just go right to the graphic to show. So while I'm talking, we'll just show the smoking cessation graphic. So if we look at that, the cardiovascular risk of stopping cigarette smoking is really an important risk that we really would like to address. So if you can see here again to show that so-called survival curve, just to orient people, it's best to be on the top. You want to be on that yellow top line because that means that you have the best chance of living out over the 5 years you can see in this graphic. So the effect of smoking cessation is really, really important. So you asked me, what do we do about smoking cessation? Well, first of all, we have to motivate the patient, and we try to show this kind of information to patients. If we have to, we'll actually show them in the office these kinds of graphs. But I think most people have now, through public health awareness, American Heart Association, the American Cancer Society, a variety of people have tried to really emphasize for the public the importance of stopping cigarette smoking. I don't know if it's in your practice, but most people say, I know. Right. They now know that smoking is really bad. What we now encounter, I think, and probably in your own practice, is not an unwillingness. I still see some people say, I like to smoke and I'm not going to quit. Those people we have, we try to still convince. But most people say, I know and I want to quit. What can I do? And there's a variety of strategies, but there are basically a few that we could talk about. One is nicotine. People know, I think, that smoking causes an addiction to the chemical nicotine. And there are a variety of strategies, whether there are nicotine lozenges, nicotine gum, or nicotine patches that can be helpful. So the strategy there is switch someone from an addiction to cigarettes with nicotine to an addiction with nicotine alone, with the hopes that once they've gotten rid of the addiction to the cigarettes and nicotine, they can deal with slowly working off the nicotine addiction by lowering the amount of nicotine they use. That can be a good strategy, but I've had many patients who have had difficulty getting off the nicotine from the lozenges or gum, continue to chew a lot of nicotine, and that's not a good strategy either. So that's one option. And there are two other things I will mention briefly. One is a drug called Zyban, which is a medicine for depression that can be helpful. And the newest medicine we have is a medicine called Chantix, which is the best medicine that we seem to have for stopping cigarette smoking. I'll just say briefly, many of my patients who have been really tough smoking addicted patients who have really tough time getting off of it have been helped by this medicine. The data says that if you use this medicine for 6 months, there's about a 50% success in getting off cigarettes at 6 months if you use the medicine for 6 months. And the way that medicine works is by blocking the brain's reception of nicotine. So those are some chemical strategies that we use to try to help patients. Of course, I think that the risks of these medicines are clearly outweighed by stopping cigarette smoking because it's such a bad thing to continue cigarette smoking. But that is a good thing, and I'm glad you asked me about smoking cessation.
Yeah, absolutely. I would add, anecdotally, I've seen quite a few people in my practice, too. I couldn't give you the exact statistic, but that same thing, achieved really good success with this new medication.
Right.
So it's
sorry, while we're on it, I'll just say that many patients have heard some recent news about Chantix and causing some problems with depression or other kinds of things. And we now recognize that that is a problem potentially, especially patients who have depression or are being treated with depression. We have to be a little more cautious with that drug. But it's sad because I think some patients say, I don't want to take it because I'm so worried about it. And I still believe in my own practice that the benefits of stopping cigarette smoking outweigh the risks of this medicine for a course of 3 or 6 months.
Absolutely. So we've talked a little, actually more than a little bit, a fair amount about risk reduction or modification. And I guess I still want to get at talking about if I continue to have symptoms that really alter the quality of my life.
Right.
What can be done? Is there anything else that can be done about this?
So the doctors who treat vascular problems with endovascular approaches is what they're called, or catheter-type treatments or angioplasties, I do these types of procedures, divide the artery blockage into 3 main areas. The area between the belly button and the groin, between the groin and the knee, and then below the knee. Those are the 3 main areas we divide things into. And these areas can be treated all with stents and balloon types of treatment. But you made a good point that we only treat patients when they get severely symptom limited. We treat heart arteries even if they don't have symptoms because we get worried if the stress test is a concern. But the leg arteries we only treat if someone is really limited. So if someone has what doctors call lifestyle limiting symptoms, if they say I can't do my shopping anymore, I'm afraid to walk, I don't want to walk, and these problems can actually have an impact on their ability to treat their other problems because they gain weight, their diabetes is a problem because they can't walk. We will go ahead and treat them. And the main treatments are first medications. And there is a medicine that's available called Plital, which can help some patients, but it helps a minority of patients. But we often will give a trial of that. That usually doesn't work. It works in a small number of patients. But if that fails to deliver an improvement in walking capacity, the next other options are revascularization type options. And revascularization means to give new blood flow to the areas of blockage. And I would broadly define that those two treatments are catheter type treatment, which I perform, which are called endovascular treatments or minimally invasive treatments in which we put a catheter into the artery and expand the artery with a balloon or a stent, or bypass options in which the artery is actually cut open and a bypass is constructed either with a patient's vein or with a piece of conduit.
Now, after that's all done, let's say I go and get a stent put in, and I feel good and better, and I'm doing the right things. I've stopped smoking, and my blood pressure is good, et cetera, et cetera. Are there things that I should keep doing as far as checking up with the doctor or tests to evaluate and make sure it's okay? Do I keep doing that?
Yeah, absolutely. I would say that it's critical to keep following up. Not only because we need to be sure that your cholesterol numbers are aggressively treated to low levels, that you're on adequate levels of medications, that the stent and balloon procedure has held up, because there is a risk, even though we get great results, there's about a 30% chance that these arteries can re-narrow and require another treatment. So it is absolutely critical that patients get regular follow-up to prevent problems and to see if there is a recurrence of problems. So absolutely critical follow-up is really necessary.
And is there anything that you can tell patients or, for example, websites to direct them to or phone numbers for them to go to get more information on this?
Yes. The American Heart Association and the vascular societies have put together a really wonderful website that if we could put up, I think, on our last graphic, the PAD Coalition website. It's called aboutpad.org. For those people who enjoy going on the web and learning about things, this is a really wonderful website that gives really basic and excellent information. You can download slides, download information about peripheral arterial disease. Again, to remind everybody, PAD stands for Peripheral Arterial Disease, and that would be a really great website for information.
Great. Well, thank you. This has been very enlightening and a good discussion about peripheral arterial disease. And this has been Matters of the Heart with Pentucket Medical Cardiology, and thank you for joining us.